Hello, guys. Welcome to the series of high yield topics of for AMC. Today, we will be covering our topic of atrial fibrillation. This is one of the most important topics from cardiology that AMC loves to test, and it is somewhat tricky in when managing it. The AMC tests you for atrial fibrillation by giving the ECG strip in the question, or they have simply stated the irregular pulse, the keyword of irregular pulse in the question. So by looking at the ECG, you can diagnose atrial fibrillation as there are no P waves on ECG. On the ECG of atrial fibrillation, a narrow QRS complexes, and the rhythm would be irregular. So just by looking at the ECG, you can diagnose atrial fibrillation. So atrial fibrillation is a kind of recurrent atrial tachyarrhythmia, and it is the most common sustained cardiac arrhythmia. So there are some lifestyle modifications that can benefit the patient when he is when he is a patient of atrial fibrillation. So weight management, alcohol reduction, or cessation, these lifestyle modifications can help the patient with the decreased recurrence of atrial fibrillation, and also the treatment of obstructive sleep apnea. So the patients of obstructive sleep apnea, they can get atrial fibrillation. So the treatment can improve the symptoms of atrial fibrillation. Most of the times, many patients are asymptomatic, but palpitations, shortness of breath, and fatigue can be present in the atrial fibrillation. And most of the times, as it is asymptomatic, so we can consider opportunistic screening during the BP measurement as it is asymptomatic. So, when do we refer the patient of atrial fibrillation? The patients who have hemodynamic instability or chest pain, acute heart failure, syncope or pre-syncope, sustained or symptomatic tachycardia, and the patient has a known history of pre-excitation syndrome, that is Wolff Parkinson White syndrome, serious underlying cause of AFib, that is sepsis or surgery. So we have to refer the patient to the specialist. And if the patient has controlled ventricular rate and there is no other significant heart disease, this case can be managed by GP. So, very important approach when dealing with the atrial fibrillation is as soon as the atrial fibrillation is diagnosed, we have to assess that stroke risk and start anticoagulation, because atrial fibrillation has a very lethal complication, that is thromboembolism, and a stroke can occur if atrial fibrillation is not treated urgently. So the anticoagulation is a very important part of management. Assess the stroke risk and start anticoagulant therapy if appropriate, unless they have a very less stroke risk or unacceptably high bleeding risk. So these are two cases when we do not start the anticoagulation or in atrial fibrillation if the patient has unacceptably high bleeding risk or he has a very less stroke risk. When we will see the CHA2DS2 score, so we can check who have the very less stroke risk. So to assess the stroke risk, we have the CHA2DS2 score, and you have to learn it. But before that, we have three kinds of atrial fibrillation. There is paroxysmal atrial fibrillation, that is the self-terminated episodes within 48 hours, and they can continue up to 7 days. And this is cardioverted within 7 days. If the atrial fibrillation is considered persistent, if the episodes are for more than 7 days, and we have to do the rhythm control, and they are cardioverted after 7 days. So the paroxysmal one is cardioverted within 7 days, because it is less than 7 days. It continue up to 7 days, and the persistent one continue for more than 7 days. So that's why it is cardioverted after 7 days. And the long-standing and persistent atrial fibrillation would be considered if the episodes are occurring for more than 1 year. And now we have to decide to use the rhythm control. Now, a very important part of the atrial fibrillation, and you have to learn it, that is CHA2DS2 score. For C, we have the congestive heart failure, and that is the +1 score. All of the risk factors have +1 score. The two very important, that is the age of 75 or more, and previous stroke, TIA, or thromboembolism history. These two have the +2 score. So all of them have one +1. So what are these risk factors? For C, we have congestive heart failure, H for hypertension, A for age 75 or more. So it is given the score of +2. D for diabetes, and S2 for previous stroke, TIA, and thromboembolism history. Then we have VA and SC. For V, we have vascular disease, that is the PAD or complex aortic plaque or history of MI. That is also given the score of +1. Age is 65 to 74 years, that is +1. If the patient is more than 75, that is the +2. And if he is 65 to 74 years of age, he is given the score of +1. Then we have the sex, that is female. Female age is given as the +1 score. Female gender is a risk factor, but it only increases the stroke risk if other risk factors are also combined. So it is considered the risk factor, and it increases the stroke risk only when other risk factors are combined. So if there is the male patient and he has the score of 2 or more, and female patient 3 or more, he is advised oral anticoagulation is a must. And if the patient is male, score 1, and female is equal to 2, oral anticoagulation is recommended. And males score 0 and females 1, anticoagulation is not recommended. So only the case where the anticoagulation is not recommended is the male score is 0 and female score is 1. Female score is 1 would be when she or because the gender of the female gets 1 score. So anticoagulation is not recommended, and otherwise, the anticoagulation is recommended in all of the above cases. And another thing, atrial fibrillation can also be caused post-operatively after surgery. And in these cases, the precipitants would be hypoxia, sepsis, or electrolyte imbalance. So, if you treat the precipitants post-operatively, and if the patient has atrial fibrillation can subside. So, if the patient is stable, we it can spontaneously reverse. And if the reversion does not occur under 24 hours, and he is asymptomatic, we are going to go for rate control. But if the patient is symptomatic, we're going to go for the rhythm control. And if the atrial fibrillation is persistent, we are going to treat it as any other new onset atrial fibrillation. So that is for the post-operative atrial fibrillation. Now, anticoagulant therapy to prevent thromboembolic events in atrial fibrillation. What is the anticoagulant therapy that is given in this case? So, if the patient has a history of rheumatic mitral stenosis, or he has a mechanical heart valve, and it particularly increases the risk of thromboembolism when he's having atrial fibrillation. So, it is specifically the patient, these two patients are treated with warfarin and in the name of anticoagulant therapy. All other patients, the drug of choice for anticoagulation are direct oral anticoagulants, or even with other valvular heart diseases. Not all valvular heart diseases get to have warfarin, only the rheumatic ones and the mechanical heart valves. Other valvular heart diseases like mitral regurgitation, biprosthetic valves, they can be treated with direct oral anticoagulant and a direct oral anticoagulants. And in this case, antiplatelets are not recommended usually for anticoagulant therapy, but only in the case of acute coronary syndrome. So if the patient has acute coronary syndrome, the patient is given antiplatelet therapy and also the anticoagulant therapy if the patient is having atrial fibrillation. So you have to keep that in mind. So the direct oral anticoagulant agulants, we have factor 10A inhibitors. That is the apixaban, rivaroxaban. Apixaban is contraindicated when creatinine clearance is less than 25. Rivaroxaban is also contraindicated when creatinine clearance is 15, less than 15. And now we have another drug, that is the direct thrombin inhibitor, dabigatran, and it is contraindicated when creatinine clearance is less than 30. Warfarin is also indicated in severe kidney impairments, or if the patient has APLA syndrome, that is antiphospholipid syndrome. So warfarin is indicated in these two conditions also. So the indications for warfarin is the mechanical heart valve, rheumatic mitral stenosis, or severe kidney impairment, and antiphospholipid syndrome. And we have to adjust the warfarin dose to achieve the INR from 2 to 3. Starting with the management of the patient with atrial fibrillation. So first of all, you have to assess the patient as through the vitals, as the patient is hemodynamically stable or unstable. In the question, the hemodynamic instability is shown through the blood pressure, systolic blood pressure of less than 90, usually in the cases when AMC tests you. So hemodynamically unstable patient is always to go for the immediate DC electrical cardioversion. But the patient is, on the other hand, we have the patient who is hemodynamically stable. Now we are going to check if the patient is symptomatic or asymptomatic and check the ventricular rate. So if the ventricular rate is increased and the patient is symptomatic, we are going to go for the rhythm control and rate control. In rate control, first we are going to go for the rate control when there is increased ventricular rate regardless of the symptoms. And we are going to do the rhythm control only if the patients who are more symptomatic or decreased left ejection fraction, or rate control was not effective. And also the patients who are recently diagnosed atrial fibrillation, which is less than of 12 months. So these are the indications for rhythm control, and we should attempt to restore the sinus rhythm. But there is a case, if there is a case and it says that the patient is asymptomatic, there is no increased rate, and only there is given the irregular pulse, or there is the ECG that is given having the irregular pulse on ECG. So what would be your approach to that patient? First of all, if the patient is asymptomatic, there is no increased heart rate, and the patient is hemodynamically stable, first of all, you have to go for the anticoagulation. You have to assess the patient for stroke risk, and that is through the CHA2DS2 score. And if the patient falls into the category of CHA2DS2 score of more than 2, you have to go for the one, or more than one, you have to go for the immediate anticoagulation therapy, because the patient of atrial fibrillation has increased risk of thromboembolic event, and this is basically the main thing you have to prevent the patient to go. You have to prevent the patient from. We have, if the patient is hemodynamically stable, we are going to check if we have the specific time duration. So if the patient is hemodynamically stable and he's presented less than 48 hours from the onset of the symptoms, we are going to go for the rate or rhythm control can be offered, and anticoagulation is given at the time of cardioversion, that is during the rhythm control. And if there is a doubt about duration, that you do not know when did the atrial fibrillation started, so you are going to treat is as the atrial fibrillation of more than 48 hours. On the other hand, if we have the case that if the patient has presented of more than 48 hours from the onset of symptoms, we are going to first do two main things. If the duration has passed for more than 48 hours, or the duration is unknown, first we are going to exclude left atrial thrombus because of the increased risk through transesophageal echocardiography. So first we have to rule out this, and then we are going to anticoagulate for 3 weeks. First step is this, and then we are going to anticoagulant for 3 weeks. Before these 2 points, we do not perform acute cardioversion. And if both of these are not done yet, rate control is preferred, not rhythm control. So rate control is preferred if the patient has presented in more than 48 hours, and one or two cannot be done. These two things cannot be done. And if mural thrombus is excluded, we are going to cardiovert with the anticoagulation continued for 4 weeks. So mural thrombus is excluded. Now we are going to cardioverse the patient with anticoagulant and continue for 4 weeks. So that is the approach, keeping in mind the time duration of her presentation. Now, for anticoagulation, we use here unfractionated heparin, low molecular weight heparin, or direct oral anticoagulants. So that is it for the part one of atrial fibrillation. In part two, I'm going to be telling you about the drugs of rate control, rhythm control, and we are going to be going in further detail. So that's it, and stay tuned for the part two. Thank you.